really busy for all of you, and I hope you all are doing well and making it through. I just want to thank Barb for inviting me, and also to mention how much foresight she and Michael Vidiello and the other organizers of this series had in developing the online part of it years ago as a way to increase access, but also as a guarantee that if people aren't able to get together, that they can still participate. So it's a real testament to their hard work in improving geriatrics education that we can be here together today. So as Barb mentioned, it'd be great if you could post questions on the chat box. I think everybody's audio is muted, and I can't see the chat, but if anything comes up, please just type it in, and Barb is monitoring that. So what I wanted to talk about today is how to approach dementia. And this is a little bit different than standard, what is dementia, what to do with it. And instead, I'd like to open and close with the reminder of what really is important, which is the whole person. It's not a medical issue primarily. It's not a brain problem primarily. It's a problem with the individual's ability to participate in the world. And I'm going to try to bring that home a couple of different ways. But in the middle, we'll have to deal with a lot of the more specific and technical issues involved in how to define dementia. But I want to make sure that we don't forget this big issue. If you're looking for more specific details in a structured way, I'd recommend this curriculum that's at the HRSA website. You can also just search for HRSA dementia, and you can see what the 7 modules are there. And they're nicely done and can be a quick reference if you have additional questions, or my email's at the end, and I'm always very happy to address any questions that you might have. In this image, I try to show what I'm getting at with regard to addressing and keeping our attention on what really matters. When you think about medical problems, you usually think about them in the way that the bottom graph, bottom figure looks, which is you define what the problem is. You come up with the definition that would be in a dictionary, or that everyone has agreed on, and then you talk about the differential diagnosis, what conditions are not involved, what the cause is, if there's different variations, how you could test to define if somebody has a disease, how often it happens, like the epidemiology, and then the natural history, and maybe something about the treatments. And that's all very medical. And what I have realized over years of working in dementia is that material is interesting and academically important, but it really doesn't help you very much in caring for people with dementia. In fact, a lot of it is almost worthless in terms of doing the right thing to help patients and families as they deal with this condition. And I think what's more important by far is appreciating why dementia is a problem for individuals and their families. And if you can get that real emotional sense, and also recognize the different ways that dementia impacts people's lives, you will be able to help them in the most productive way. To put another way, if you believed that dementia was caused by evil spirits or pixies or some kind of magical cause, but you considered the person involved, you would be of much greater utility than someone who would won a Nobel Prize about the brain changes that happened in dementia. So really, what matters in dementia is not science, it's not knowledge, it's about understanding people and figuring out what they need and what challenges they face. And I'm going to try to keep the lecture mainly focused on that, although we do need to go into some of the details. And I hope that you'll find those at least interesting, but please don't consider that to be the meat of what I'm saying. And in fact, this lecture is just an introduction to the rest of the series, which focuses a lot more on how to deal well with patients and families who have dementia. In order to make this point more personally, I'd like to think through 3 scenarios very, very quickly. Usually you don't have to spend long considering them to realize what's at stake. So in the first scenario, imagine that one of your parents develops symptoms that would be consistent with dementia. So memory problems, they can't remember their medications, they get lost a little bit, express some paranoia about their neighbors, and your parent has left the stove on and almost burned the house down. So don't think about this medically. Just for you as a person, what would you do in this situation? How would you deal with it? And I'll list some options. You could do nothing. You could call a doctor. You could call a social worker. You could quit your job and take care of your parent. You could move your parent in with you. All of these are big activities, most of which would have drastic effects on your life. And they would push you to make some very big decisions. I was just thinking how this pandemic really has brought this home. So some of you may be in a situation where you have older friends or relatives or people who are quarantined or who don't want to get out of the house, and you're responsible for taking them supplies. And I assume that is a big change in your life, and that it would not be something that you would be able to continue to do long term without rather big adaptations. And then if you think about what your needs are at this stage, is your need for a diagnosis? Well, maybe. More your need is to make sure your parent is safe, and you'd have to figure out how to do that. Either if it's by your own intervention or by, for instance, having them move somewhere else or paying somebody to come in. But you have acute needs, and who's going to meet them? And then if you ask yourself, what would you do in the medical system in this situation? If you went to a doctor, how would they help you? What would they do for you? Maybe they'd give you a diagnosis, and maybe they'd throw a pill at it, but is that really going to help any of the acute needs? So I'm not going to give any detailed answer about exactly what would happen, but I think if you just reflect on this for a while, you'd see that there would be practical needs that you would have to deal with, and they're not in a medical realm. So the next scenario is just a further extension of this. So now let's say your parent not only has some difficulties in independent activities of daily living, but they need hands-on help managing with personal care. And also they don't remember who you are. And let's say now that the rest of your family or relatives are not able to help out, and you're the only one who can care for your parent. So in this case, what do? You quit your job, or drop out of school in order to care for them? Do you look for a place for them to live? This would be a very difficult challenge, but it is in fact one that a lot of caregivers face. So it's not entirely unrealistic. And I think you'd agree that your main needs now really are around safety and caregiving. They're not really medical at all. You might take your parent in for a checkup once in a while, but the practical issues are around eating, bathing, toileting, dressing, safety, recreation. So you can see in this case that as you get further into the dementia, it becomes even less of a medical problem and more of a functional or role problem as caregivers have to do more. It's interesting, when I used to give this talk in person, maybe I will again someday, I'd have a little discussion about what people would do, and I was always struck by the wide variation in perspectives. Some people would volunteer that they would drop everything in their lives in order to care for their loved one, for their parents. Other people would say, oh man, no, I just got, they're on their own, I'd find somebody to do it. There's clearly no right answer, but you can see what a stress it would be on you. And I'd like to step back in terms of the context and have you reflect on yet another scenario, which is, imagine that we lived in a different kind of world. Maybe some of you do have a multi-generational family living situation. I certainly know people who do. But suppose that you lived in a large multi-generational house where people are always around, and most of them don't leave the house to go to work every day. They have some flexibility, and your parent lived with you there, and they needed these day-to-day help types of activity, types of support. So, what would it be like in this case? It's funny, I've asked this sometimes, and sometimes people say, "Oh, it'd be terrible because your parent would be thrown off by all these people." And I don't really think that's the case. It's not like you're taking your parent and suddenly throwing them with a bunch of strangers. Instead, you're taking them and leaving them among people they've lived with their whole life. So I'm not trying to make it look like some kind of dystopian group living situation, but and there is real experience in this in most of the non-industrialized world, where people have larger family units and they don't lead such isolated or insulated lives, and they're there to support their elders. And in this situation, when you study it, it clearly is much easier to have dementia and to take care of people who have dementia. And in fact, in most of the parts of the world where there are multi-generational supportive communities, there really is no diagnosis of dementia per se. It's not a medicalized problem. It's just assumed that as people get old, they will need more help with activities. And there are people around to do that who volunteer. And they're afforded a lot of respect in the culture and in the family and community. So my big point here is that dementia is a social and cultural problem related to our fragmented lifestyle now with small nuclear family units and people who go off and live by themselves or live in small groups and typically away from their parents, and that ends up straining everything when an older individual requires help. So it's not a medical problem really at all in terms of the difficulty that people face with it. So I know that was a little bit of a diversion, but I hope that it helps to establish some of the general context about what we're talking about. It's very different than a medical problem where you're looking for medical management and you can separate it out from the individual's life. I understand that other conditions like diabetes, for instance, has a lot of impacts on people's lives, but it really is something separate for the most part from a way of life, whereas dementia requires a certain amount of support from other individuals, and that is the challenge that goes along with it. So let's jump into the nitty-gritty. And I'm not going to spend too long going through all this. It's pretty much the same point made a number of times about the different ways of diagnosing dementia. And then we'll talk about the specific types of dementia and look at the epidemiology of it, as well as the issue of dementia prevention, and then finally turn to some issues of assessment and management. So the first definition of dementia that I think is nice and succinct is it's a significant chronic loss in memory and/or mental functions involving structural damage to the brain. And what's important here is what these terms point away from. So significant means that it causes functional problems. If there's one detail you remember about this talk today, it should be that dementia involves functional problems. It is not just memory concerns. It is not just people doing badly on memory tests. You have to have an actual consequence in terms of your daily living for you to have dementia. So, most important point, dementia is significant. It has effects on life, and we'll see that in the other definitions also. It's a chronic problem. It does not come on over weeks or months. If that happens, you want to think about delirium instead. So typically when we talk to people who have dementia, they'll say it's been there for 3 years, usually at a minimum. If somebody was fine 3 months ago, you really need to look for something else. Dementia is a loss of capacity. So if somebody has a lifelong history of cognitive and functional impairment, such as if they had a significant head injury or have developmental delay, that is not dementia. It has to be an actual worsening. Dementia is a problem in memory and or mental functions. It's not just memory problems. And most importantly, for separating it from other conditions, especially psychiatric problems, it involves actual structural damage to the brain. The brain cells die in dementia. We'll see some pictures of that. It doesn't mean that you can necessarily identify dementia early on or track it based on the number of nerve cells there are, because there's about 10 billion and they're pretty hard to count. But it is clear that in the process of dementia, brain cells are dying. And the reason that this is important is that it differentiates it from other psychiatric conditions. We don't really know what causes other psychiatric conditions such as depression or anxiety disorders or schizophrenia, but our main assumption is that they involve problems with neurotransmitters. So, you know, your serotonin is off, your dopamine is off, your norepinephrine is off. But that the brain tissue, the brain structure itself, is the same between somebody who has even a severe form of mental illness like depression and somebody who doesn't have that at all. Whereas with dementia, there are some changes in the neurotransmitters, but really what is happening is that the brain cells are dying. So that's just a reminder, and we'll see that again a little bit later too. So here's the second definition of dementia, and this is a little more technical. We use it a lot in our reports to remind people of what we're dealing with, that it's a progressive neurodegenerative condition with functional consequences. Once again, something that gets worse, it involves degeneration, and it has actual functional changes, actual functional effects on the individual. You'll also notice that the terms that are the opposites of this, so it's not a lifelong condition, doesn't come on quickly, not part of normal aging changes, and it's not something that's insignificant or just subjective concerns. And it doesn't necessarily involve memory problems, doesn't have to be Alzheimer's. There are no behavioral requirements for this. And it doesn't mention age per se, although we'll see that it really is strongly associated with age. And it also doesn't mean that it's a fatal condition. Here's the technical definition definition of major neurocognitive disorder dementia in parentheses. In the DSM-5, which is the Psychiatry Handbook of Disorders, that is how it is officially written, with dementia in parentheses. They didn't want to get rid of the term entirely, but they didn't want that to be the only language. So for a definition, to meet criteria, you have to have a significant decline in one or more domains that are listed at the bottom, and you have to have functional effects that interfere with independence. Once again, dementia requires functional problems. Don't just have impairments in how your brain works. And then the symptoms can't be due to delirium or another condition. So you can see what those domains are. Mainly they're around carrying out specific types of challenging tasks, like multitasking or language, or doing coordinated motor activities. Almost always these go together, and there's a bunch of changes. It's not like you're just looking for an isolated one of these. In DSM-5, there's also descriptors that help to characterize what type of dementia you have. Possible versus probable is based on the amount of evidence that's available. It's specified if there is or is not behavioral disturbance, which could be psychosis, like hallucinations or paranoia. Mood problems often go along with dementia, or agitation. And then the severity of dementia is rated according to functional stage. Once again, this theme of functioning being crucial in determining the degree of dementia. People with mild dementia are able to take care of their ADLs for the most part. That's an error. That should be IADLs are affected, but ADLs are retained. Anyways, you get the point. In moderate dementia, basic activities of daily living start to be impaired, and severe dementia involves full dependence or need for assistance with all activities of daily living. I mentioned delirium before, and I want to clarify the distinction between dementia, delirium, and depression. And these are really quite different entities, but they can be easy to confuse when assessed in a single snapshot. If you see a patient in the emergency room, for instance, it may be difficult to tell. All of them involve subjective confusion, or things not being right. If you talk to a person, there's something that doesn't add up. They all have trouble carrying out activities, although it doesn't necessarily mean there's actual functional problems. These people don't seem right, and others may be worried about them. But what differentiates them is the nature of the cognitive and functional problems. So delirium is a medical problem. It is known as acute brain failure. We should probably call it that instead of delirium, because delirium suggests more of a psychiatric problem. Delirium is a medical emergency. It means that someone's brain is not working because of abnormalities. This could be either medications are off, somebody has an infection, if they've been poisoned by something, or have metabolic abnormalities, like if your sodium or potassium get way off, you can get delirious, or from extreme stress, like sleep deprivation, being in the hospital. But delirium is a sign that someone is very unhealthy, and it requires immediate attention to figure out what is going on. The hallmark is that the people really are quite confused and they can't pay attention. And they have a waxing and waning of their mental status. So if you're talking to someone and they fall asleep during the interview, they are pretty much delirious until proven otherwise, or they have really bad sleep apnea. But if they're confused and fall asleep, that's delirium, and you don't want to ignore it because it's a sign they have a real medical problem. Dementia, as we've talked about, involves specific domains of impairment. It's not rapid onset, comes on slowly, and there's functional problems. Depression can involve cognitive difficulties, and two of the hallmark symptoms of major depression are impairments in concentration and decreased interests. But really, when you test people out, they're able to pay attention, their memories work okay, and they don't have substantial cognitive problems. So if somebody is depressed, you don't want to ignore it, but you don't want to call it dementia. So let's turn more to how often dementia occurs and what the risk factors are. The single most important risk factor for dementia, by far, as you might guess, is age. At age 65, about 1% of the population has dementia. Everybody over 65, it's about 6 to 8%, and over age 80, it's about 30. So there's a lot of people out there with dementia, and as you can see from this graph, as you get older and older, the prevalence of dementia increases. This is lines representing different parts of the world. They're all industrialized countries, but they show a surprisingly similar trend. We still don't really know why this occurs. One of the greater unsolved mysteries, I assume with all of the issues in the pandemic, there's going to be more attention to the factors that make older people at risk for certain diseases. Personally, I'm baffled about the age distributions of COVID infection because they really do go up, and it's not quite this same curve, but it's roughly something like that. So there's some kind of change that happens with age that we really don't fully understand. I'll talk a little bit more about the risk factors and preventative factors. So let's talk about the types of dementia. This graph is to represent that there are not isolated subtypes. The ones we'll talk about today are Alzheimer's, Lewy Body, vascular, and frontotemporal dementia. The others that are thrown in there are NPH, which is normal pressure hydrocephalus, and infectious and toxic processes, which are not really dementia per se. And then FTD is frontotemporal. The point is that they don't occur in isolation. And in fact, Lewy Body is probably pretty well represented there. That Lewy Body dementia occurs more commonly in combination with other conditions than it does on its own. And there is a very large overlap between Alzheimer's and vascular. So as you're thinking about these, don't assume that they have to be mutually exclusive. In fact, they share a lot of traits. This is a quick reminder of what the brain looks like and the different lobes. The yellow lobe is the frontal lobes, pink lobe on top is the parietal lobe, blue one in the back is occipital, and the purple one at the bottom is the temporal lobe. The changes in Alzheimer's are mainly temporal and parietal, so that middle part of the brain, and then later you get a more general degeneration. We don't really know why the changes start there, but the other parts of the brain, especially the blue part which handles vision, are mainly retained. And dementia is a change mainly in the outer layers, in the cortex of the brain, and it does not affect the deep parts of the brain, except for Lewy Body disease, which we'll talk about. And then the part number 2 down there is the cerebellum, and that doesn't seem to be affected very much. So the types we'll talk about are listed there: Alzheimer's, vascular, Lewy Body, and frontotemporal. And then we'll mention this concept of reversible dementia, even though it isn't really a very useful concept to think about, because it really doesn't fit the definition that we're using. The story of Alzheimer's disease is very interesting. If you ever looking for a good historical read, online there's a bunch of stuff about the discovery of Alzheimer's disease by Alois Alzheimer, who's pictured on the left there. And his first patient is a woman whose photograph is there. Her name was Auguste H. And she had a different form of mental problem than most of the people who were institutionalized at that time. She had more jealous delusions and cognitive problems, whereas most of the other people had non-specific mental impairments that were related to the most common cause of cognitive decline in those days, which has disappeared, at least in most of the world, and that's neurosyphilis. So it's funny how 100 years ago, the scourge of geriatrics was neurosyphilis, and people with neurosyphilis filled up institutions, and everybody was looking for a cure. And finally, there was a cure, and it largely went away. But at that time, there were very few cases of what we know as being Alzheimer's disease, which is kind of funny. In that respect, Alzheimer was kind of a brilliant diagnostician to identify these unusual characteristics in this one patient. Nowadays, if you went into a nursing home, you couldn't turn around without bumping into somebody who has Alzheimer's. And so it wouldn't be that remarkable to say, oh, here's these people who have a certain disease and we can figure out what's going on in their brain. But in fact, for Alzheimer, it was an actual leap that he figured out what was happening. So when Auguste H. died and he looked at her brain, he found those inclusions. That's Alzheimer's own picture of them. They're not very not very clear to us, but they show a distinctive pattern that then appeared in the brains of others. And what we now know them to be are plaques and tangles. You've probably heard this phrase. So the plaques are outside the cell. They're made of amyloid, which is a normal protein in the body, except it's misfolded. So normal amyloid is everywhere, in every cell in your body, and it kind of helps all the proteins stay properly bound. It's kind of like a giant glue for everything, and it's soluble. It's water soluble. Whereas if you misfold it in a certain way, it is no longer water soluble, and it gloms together in these little collections that are amyloid plaques. And then the tangles are inside the cell, and those are made of a protein called tau, and that is part of the skeleton of the cell. It helps keep the cell intact, and when the tau collects together, it forms what looks like these tangles in the cell. Tau also is a totally normal protein in every cell of your body, and probably the tangles are a marker of cell death. It's not like they're a separate process or a sign of an infection. So unfortunately, it's not like we have the thing that causes Alzheimer's, and that if you could keep that thing out of the body, you would be able to prevent or fix it. Instead, the signs at a cellular level of Alzheimer's are a marker of the cells dying. That's a little bit technical detail, but it's interesting to reflect on what's going on. So this is a schematic of how this happens, where you have APP, which is amyloid precursor protein. It gets broken down in the wrong way in this beta form that's shown in B, and then it all gloms together, forms a plaque, and then the cells die. And this picture, which is now pretty old, points to a lot of ways that you could intervene, but unfortunately, really none of them have worked. And if you consider it in the the way that I just mentioned, where this is not really the cause of dementia, but rather something that happens in dementia, you'll see that interfering with most of these little steps probably isn't going to solve the problem, because it's not like all you need to do is stop something from getting into the body. What you need to do is change the whole cascade of activities, and we simply don't know how that works right now. The end result of this is that neurons have died. I mentioned this before. It's very hard to count exactly how many, but probably on the order of billions. If you've got 10 billion neurons, over the course of dementia, you've lost at least a couple billion of them. You can see that in the CAT scan on the bottom, where the normal brain on the right has nice folds that without space in between them, the brain tissue is pushed out all the way to the skull, and on the left you can see it's all shrunk. So that's the basic change. And then if you look on the top picture at the lower level, you see in these shapes in here, which are, I don't know if I can get the pen to work, maybe not. Anyways, the little things that look like curlicues or seahorses are the hippocampus, and those are the areas that are often affected first in Alzheimer's disease, but over time the entire brain shrinks. So what happens in Alzheimer's? It has more detail than the other than the other forms of dementia. It has to involve a memory problem and one or more problems with speech, motor activity, recognizing things, or carrying out complex tasks. And then there has to be a functional impairment related to the cognitive deficit. Reminder again, functional impairment must occur or else you don't have dementia. And then also, there can't be another cause for the cognitive problem. Some of the other causes that we see commonly and that you want to be on the lookout for are delirium, especially medication side effects. In geriatric psychiatry, we say that the three top causes of delirium in older people are medications, 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 or urinary tract infections commonly. Sleep apnea can cause cognitive difficulties. Problems with vision and hearing can make it difficult for people to interact with the world and can make it seem like they have cognitive deficits when actually they don't. And then mental health issues, especially PTSD, can cause problems with paying attention and interacting, and those can mimic cognitive deficits or dementia when really they're not. But all of those things are quite different clinically than what you see in Alzheimer's, which is a slow, steady decline in functioning and cognition over years, over the years. Once again, it's not months. If somebody has problems over a period of months, you need to investigate other areas. Usually patients have impaired insight. If you ask them how they're doing, they'll say, I'm fine. You got any difficulties? Nope. How's your memory? It's fine. Yes, insight is usually the first thing that goes, even before people have real specific cognitive difficulties. Perhaps surprisingly, people don't present for assessment until somewhat late in the disease. On average, it's about 3 years into the course of symptoms before people will get an evaluation. And when they do have done tests of people who come in for their first assessment to see how bad they are, and then they get a diagnosis of dementia, the average score on a 30-point test is about 20. So it's very much different than other serious medical problems where you would get medical care pretty quickly. The most extreme one is vomiting blood. If you're throwing up blood, you're not going to wait 3 years to get it treated. Whereas with dementia, you usually get by and other people pick up the slack, and you have to have a lot of significant functional problems before you will get it assessed. Alzheimer's involves little change from day to day. I'll ask families about this, like, how is it, today compared to yesterday? And usually they'll say, it's pretty much the same or getting slowly worse, but it's not a lot of fluctuation. And then the overall course of dementia is typically about 10 years long, give or take. And typically people die of other medical causes, although if they progress far enough, then ultimately the whole brain is affected and people's autonomic nervous system no longer sustains them, and they will aspirate and develop a pneumonia. But it's roughly a 10-year course. Real quickly on the different stages of dementia. The mini-mental, I don't think anybody uses that much anymore. That's the 30-point test. Now you probably use a MoCA. Mild Alzheimer's lasts about 2 to 3 years after diagnosis, which is, as I mentioned, usually a couple years after symptoms developed. It mainly involves memory and more complicated cognitive tasks, and there are some difficulties with daily activities, but not a lot. Moderate Alzheimer's is a far lower score. People showed deficits in carrying out more simple tasks, and they typically lose independent activities of daily living and may need some assistance with activities of daily living. And this is typically where psychiatric symptoms appear. And this makes sense because the psychiatric symptoms are generally due to people recognizing there's a problem, like my wallet used to be there and it's not there anymore, but not the cognitive wherewithal or bandwidth to see the big picture, which it would be like, my wallet's not there because I put it in the drawer. Instead, it's my wallet's not there, somebody's here, they must have stolen my wallet. Or my wallet's not here, somebody stole my wallet. And that's what gets people agitated. Or you can appreciate if you don't recognize folks that you don't see very often and they keep coming into your space, it would really throw you off. So this is oftentimes the most difficult stage of dementia because people still retain the capacity to recognize there's a problem. In the later stage, people show lots of problems, difficulty with language especially, and people can get very agitated at this stage, although oftentimes they're not even really aware there's any problem. So this is where real acting out might occur, but it has to be in the setting of somebody recognizing something is wrong. And at the very late stages, you get more neurologic problems. Despite this convenient framework, there's a nice saying the Alzheimer's Association has, which I used to think was a little bit cheesy, but I think it has a lot of truth to it, which is when you've seen one case of Alzheimer's, you've seen one case. Every case is different. There are people who retain their language skills really well through dementia, who didn't have great language skills before, but they keep them. But their personalities change. There's other people whose personality seems to stay exactly the same, but their cognitive multitasking ability falls apart. So it is difficult to predict what's going to happen. And unfortunately, this makes it hard to tell caregivers what to expect. It would be nice, for instance, if we could say, personality change happens only in people who had difficult personalities before. But that really isn't so. And the hardest cases are when you have someone who had been a relatively sweet and gentle person who develops dementia and becomes more agitated and disturbed. So just don't generalize too much about what happens. The genetics of Alzheimer's are interesting, mainly to be able to tell people not to worry about it. So there's two main categories of dementia. One is early onset and one is late onset. Early onset dementia, which is young, like 40s, 50s age, is far more likely to be a familial syndrome that's associated with genetic variants. And there's lots of study around the world now about families that have a bunch of dementia cases, because it's thought that we could identify the genes that are at play. In Peru especially, there's a very large study trying to do gene analysis of pretty much everybody in a certain area and in certain families where they develop dementia in their 40s. However, most of the dementia in the world starts considerably later, and it's not familiar, it's sporadic. So these cases of sporadic dementia do not have many, if at all, highly specific genetic variants. There's one that's apolipoprotein E4 that somewhat increases risk, but it's certainly no guarantee, and you have to have 2 copies of it to have it be considerably higher risk. And the way we tell people about this is to mention that the vast majority of people with dementia do not have a relative with dementia or who had dementia. So it's a big concern when somebody is diagnosed because they're worried about their children and their grandchildren and brothers and sisters. And we can pretty safely tell them that even though there is some slight increase in risk, that if they develop dementia at an older age, they don't need to worry about that. And likewise in reverse, if they had a parent who had dementia, they shouldn't lose sleep over the fact that they would get dementia at the same age. When it all comes down to it, we don't know what causes dementia, unfortunately 100 years later. And it's probably the result of random brain changes that accumulate over time in difficult to describe ways. And when they line up in a certain way, they start a process that continues on its own. And hopefully we'll be able to sort those out. I sometimes call this like losing a game of bad luck bingo, where some people may have certain bingo squares that are set off, checked off in advance. Other people may have bingo squares that will never be checked off. But as you accumulate hits on your brain's bingo board as you get older, eventually you're going to get one of them that lines up in the right way, and that starts this dementia process that for whatever reason continues on its own and does not reverse. So hopefully with more science we'll be able to figure out what these things are and figure out ways of intervening. You may have heard that there are more dementia cases now in the world, and the question is why? When I was learning about this first, there were people who were hypothesizing that maybe it's modern exposures like aluminum pots or power lines or some infectious agents. And that certainly deserves attention, but really the single reason why there's more dementia now is that everybody lives longer than they used to. So the average age, or the average life expectancy at birth now is about 20 years longer than it was 100 years ago. So we're dying at roughly age 80 now, although unfortunately that number hasn't continued to go up for Americans. But we're living a lot longer than people did 100 years ago. And when you look at the bottom graph, you see that the rate of dementia starts going up a lot at about age 75. So the scale on the left isn't real good because it's a logarithmic scale. So really the line goes like that instead of being a line. But what this means is that if people die before age 80, you're not going to get that many dementia cases. And if people die at age 90, you're going to have a lot of people who develop dementia. So that's why we have more dementia now, is that we all are living longer. The next logical question would be, well, can't we prevent it? And that would make a lot of sense. It would save a lot of individual suffering and be good for society. because of the cost of caring for people with dementia. And unfortunately, I got kind of bad news on this, that really there's no clear dementia prevention strategies that work. This is a report that's a little dated now, but nothing as new has come up that substantially changes it. And when they did a full review of the literature about modifiable risk factors, they found there's really no strong association of just about anything, including pharmaceutical agents or dietary supplements. In a way, this is discouraging because it means that probably not going to be able to decrease your chances substantially of dementia, at least by taking a pill or a supplement. But in a way, it's liberating also, because it means that if you got dementia, you probably just were unlucky, that the people with dementia didn't, in effect, bring it on themselves. So there's two ways to spin that. And I personally expect that there will be more understanding of this in the future, and maybe we will identify some positive factors that can be intervened. But right now, there's really no good recommendations. As another example of how you're probably not going to prevent dementia, just three people who developed dementia, both of this is Ronald Reagan and Margaret Thatcher, leaders of major countries, very, very fit, engaged in a lot of high-level activities. You may have differing opinions about whether they were good decisions they made in their offices, but clearly they had to use their brains in what they did, and both of them developed dementia. This guy is the supreme example of how somebody who shouldn't get dementia did. So this is Claude Shannon, who the first information technologist, is a brilliant engineer who came up with the system, the theoretical system behind the computer. Like, there hadn't been for his work, we wouldn't have computers now, probably. You can see he was a fit, healthy guy. He spent his time riding his unicycle around. He enjoyed juggling, and he was really good at chess. Like, every possible smart, healthy thing you could do. Ate well, no bad habits, and you'll guess what he got. Yeah, it was dementia. So this is a real challenge if Alzheimer's disease or dementia is caused by doing bad behaviors, because it just doesn't add up. I see patients in clinic who run marathons in their 80s, and they develop dementia, who have been vegetarians their whole lives and never smoked a cigarette or had an alcoholic drink. So it's, and at the same time, we see patients who have out of control diabetes and blood pressure, high blood pressure, who have the worst diet possible and smoke and drink a lot, who don't get dementia. So I'm not saying that you want to encourage bad habits, but when you really look at the data, there is no good scientific basis for being able to guarantee that you're not going to get dementia. All right, that was a little interlude about dementia prevention. I want to return now to the other types of dementia quickly. Vascular dementia, most important thing is it's not strokes. Strokes are blockages in the medium to large vessels in the brain. Vascular dementia is changes in the small vessels in the brain. So if you have a stroke, part of your brain is injured, and then it can take a long time for it to grow back. But you don't expect somebody who has a stroke to keep getting worse just because they had the stroke. Instead, people stabilize typically, and a lot of times their condition improves. So neurologists generally give a year before they'll say that somebody is to what their new baseline is going to be after a stroke. And even then, they can have changes. Their brain is still plastic, and it can still adapt. However, in vascular dementia, which is these small vessel changes, you end up getting the same kind of deterioration that occurs in Alzheimer's disease, and we don't really know why. They overlap a bunch. Hypertension is a risk factor for vascular dementia, as is smoking and high lipids. But the weird thing to me that I really can't figure out is people who have these risk factors and develop what we call vascular dementia start on this downward slope, and then you fix all of that. You fix their blood pressure, you get their cholesterol better, they stop smoking, and yet they still keep getting worse. So there's something that starts, and it's probably that Alzheimer's and vascular dementia are part of the same clinical syndrome that involves changes to the small vessels in the brain and then cell death. But it's not like vascular dementia is caused by and then can be reversed by vascular risk factors. So to boil all this down, it's okay if you want to lump together vascular and Alzheimer's dementia. You don't need a special separate category for vascular dementia. This is an interesting way to exhibit. The patient on the left had a big stroke. You can see the white arrow sign showing you that there's part of their brain that's missing. The patient on the right and on the other patient on the bottom had small changes. These are periventricular white matter hyperintensities that show big-time vascular disease in their brain. Clearly, the brain on the top left looks a lot worse, and yet it works a lot better than the other ones, which is surprising. So you can have a big stroke and still sustain a lot of functioning, but if you start this progressive decline that ends up killing your brain cells, you will have more difficulties. This is a quick reminder that when you study this systematically, as happened in the NUN study, you see that there is a very big overlap between Alzheimer's disease and vascular disease. And what they found in the brains of these nuns on autopsy, they had done cognitive tests on the nuns during their life to see how they were doing, and then they all had autopsies. So what they found is that the nuns who had Alzheimer's and vascular pathology had a very high likelihood, like 90% chance, of having cognitive problems during life. But those who had only vascular type pathology, only plaques and tangles without changes to their blood vessels, had a much lower likelihood of cognitive problems, like 30%. So probably what we're seeing is that the real dangerous situation is not plaques and tangles, but rather plaques and tangles plus blood vessel changes. And this is also confirmed by studies of normal adult autopsies, where you take people who die at different ages, and in people's 90s, it's more common to have plaques and tangles than it is to have none of them, even without any symptoms. So all this is just to untangle the idea that there's a causative agent that's like a specific key that gets in the brain and causes Alzheimer's. Instead, what you're seeing are effects of injury to the brain that we don't fully understand. All right, so let's go quickly into Lewy body disease. Lewy body is, the dementia involves these things called Lewy bodies in the brain. There are those funny looking purple dots on the left and brown things on the right. They occur throughout the brain. They're not just in the outer layer, which means that other parts of coordinated activity are affected. Lewy body is quite common, and if you ask around, you will find it. As I mentioned at the outset, it happens more often in combination with Alzheimer's than alone. The findings that are unique to Lewy body disease are Parkinsonism, which is all the symptoms that happen in Parkinson's. People have a posture that's stooped over. They can have a pill rolling tremor. Their gait can be shuffling. Cogwheeling, which is where your arm kind of catches as you pull it down. And then there's a facial expression known as masked faces, as if somebody was wearing a mask. So they would not show emotion on their face. It's funny how often families will use these very terms to describe what's going on. They'll say, oh, he's kind of shuffling along and he's stooped over and it's like he's wearing a mask. And those are real tip-offs for this other form of dementia. The other unusual finding is visual hallucinations, which don't occur in other psychiatric conditions very often. And they're usually not frightening. It's more like little people up in the carpet by the TV. Or I have a patient who would call his wife over to their plate glass window and say, hey, honey, look at those interesting animals out there. I've never seen them like that. There was nothing there. So it's kind of funny that you could have visual hallucinations that are pretty well formed, but not to be upset by them. Lewy body, unlike Alzheimer's, involves a lot of waxing and waning, day to day or even within a day. So patients will often say that one day is good and the other day is lousy. And people can often have memory problems after the other symptoms. So they may develop motor symptoms first and then have memory difficulties. In general, Lewy body is a rockier course than Alzheimer's because it involves these other symptoms and especially the psychiatric ones. And the only really important reason for identifying Lewy body disease is that these patients are especially sensitive to antipsychotic medications, which are oftentimes what people throw at the symptom of visual hallucinations. So if you ever encounter somebody you suspect has Lewy body dementia, please tip them off about this point and make sure they exercise caution in using antipsychotics. Frontotemporal dementia is an odd form of dementia. You may never see a case unless you work on a specialized setting. It involves slow damage to the frontal lobes. You can see it initially on brain imaging. The frontal lobes, as you remember, are what kind of makes us human and socially appropriate. So if you damage them, people show odd personality changes. They can get very disinhibited and inappropriate and may have trouble carrying out complicated activities. And this is a very strange form of damage to the brain because it starts in the front and then kind of progresses back. And eventually you get more cognitive and memory problems, but initially people can show really perfect, normal cognitive abilities on tests or tasks, but they can have rather pronounced personality problems. This one tends to have a much more familial basis, so you get a family history more often, and it comes on earlier than Alzheimer's or vascular disease. So this one would be nice if you could diagnose it in people who are just kind of inappropriate in your colleagues, but it's pretty rare, and most inappropriate behavior has another explanation. But if somebody has unusual symptoms, then they can merit a workup. Here's a picture of the changes that happen in frontotemporal disease. It's not subtle. As you can see on the left, the tissue is pretty normal, and on the right, it has severely atrophied. So it's a weird condition. All right, and then want to make quick mention of what are called reversible dementias. And sometimes people will say that a patient has a reversible dementia. You can see what that big list is. And in fact, what all these are is medical problems that have cognitive consequences. So if you get heavy metal poisoning, you get a lot of lead exposure, you will have blunting of your thought processes. Or the picture on the bottom right, the white shape in the middle looks like a panda bear. It's an actual MRI sign known as the face of the giant panda. And that's accumulation of copper in the brain that happens in Wilson's disease. And that involves problems with thinking, and it can look kind of like dementia. But really, all these things are not dementia per se, because they involve changes of a known cause, and they're not progressive in and of themselves. And most of them, if you fix the underlying problem, go away, or at least get better, or at the very least, don't continue to deteriorate. So as a reminder about what dementia being a progressive neurodegenerative condition, if there's no degeneration, then you really shouldn't call it a dementia. So please don't memorize this list. It's more just for your interest and in order to bring home the point that what we're really dealing with is a process that happens on its own and that's not just a consequence of a medical condition. So let's talk quickly about working up dementia. And a lot of the other talks in the series are going to be about appropriately dealing with people with dementia. The basis really is a good history, especially from somebody who knows the patient, like a spouse. You're better off asking them, how has he done over the last 3 or 4 years in terms of his activities and memory, than you are asking the patient, how are you? Because the patient will usually say, I'm fine. The single most useful question for me is to ask the loved one, are there things you have to do for him or her that he or she used to do for themselves? And if the answer is no, then you got to wonder if there really is dementia, because that implies there's no functional decline. If it's yes, then that suggests that there has been functional decline and you want to get more detail. So the basis of a diagnosis really is a good history. We do a basic physical exam to make sure there's none of those other findings, and that's where you could pick up on things like Lewy Body disease pathology. You want to make sure this didn't come on acutely and that it's not delirium. And then there's all those reversible causes you want to look into. And if things line up, like if there's a pretty consistent story about what the symptoms are and it fits with Alzheimer's, you don't need to do a bunch more workup. If there's unusual findings, like somebody's can't use their left hand, or they're having visual changes, like blind in part of their eye, or they're falling, that's when you'd want to do more workup. But you don't need to do an extensive workup on everything. We do basic screening tests just to make sure we're not missing something, although frankly, I've never in 15 years had any of them inform our clinical care. Once in a while we'll find an abnormality, but it doesn't explain dementia. And then neuroimaging, like a CAT scan or MRI, are not routinely indicated for a workup because they just don't add much. We do recommend some cognitive testing. This is the mini-mental, which isn't really used, but it applies to the other scales too. But what it shows on the graphs and the table is that the score is contingent on age and education. So the top right graph is the mini-mental score based on education level. You can see that the spread gets a lot narrower at higher educations and the scores get higher. So somebody has very low education, they can do really pretty badly on the mini-mental and it doesn't suggest a problem. Likewise, as people get older, the spread gets wider and the score gets lower. So just because somebody with low education gets a score of 20 on the 30-point test doesn't mean they necessarily have dementia. This is a quick cognitive assessment. If you're looking for one test to have ready in your back pocket to assess cognitive status, it's the mini-cog that was developed at the University of Washington by Sue Borson. Real quickly, you ask people to remember 3 words or 3 items like apple, table, and penny, and they repeat them back to you until they can say all of them. If they can't do that, then they fail. But you give them a couple tries, and then you have them draw a clock, and you ask them to put the hands on and then put the time on to be 11:10. And then after they finish their clock, you ask them the 3 items. It's 1 point per item, 2 points for the clock. You can see how the clocks are scored. If you only get a 0 or a 2 on the clock, no partial credit. And then you add those, and if somebody has a 3, 4, or 5, you assume they're probably okay. And if they're a 0 to 2, that's a sign of a real problem. It's funny how well this correlates with real capacity without having to do a bunch of additional questions. So if you're looking for something to have, I'd recommend this one, and you can try it out on some people. And you don't need to have a form even to use it. I want to address real quickly one final issue about screening. And I get an email at least once a week about great new findings in dementia and how cool it is, what we're learning. Unfortunately, most of it never pans out. And I want to think through real quickly what the consequences of screening would be. And to do a little bit of math. I don't want to spend forever on this, but trust me. So this is an actual blurb I got saying that there's a new blood test that predicts Alzheimer's with 90% accuracy. And you think, hey, that sounds great. We can test for Alzheimer's with a blood test. But suppose you do this test, and you have a population of, and it's 90% accurate, and you take 1,000 people who are age 70 to 80, and 4% of them have dementia, which is about the figure. So if you look at all the numbers of who would get a positive and a negative test, when you run all of it, what it means is that if you have a negative test on this, your likelihood of having dementia is very low. That's great. You'd be like, well, I got a negative test. Therefore, it's pretty solid negative diagnosis. But if you get a positive test on this 90% accurate test, your chances of not having dementia is still 73%. Has an incredibly high false positive rate. That's the problem with screening with tests that aren't totally accurate, is that you end up with a lot of false positives. And what's somebody supposed to do with this result then? If you do the test again, then you still have to interpret what that means. And basically it means you're telling somebody they've got this diagnosis that's going to get them into significant trouble and be a burden to their family, and they're having to live with this, even though almost 3/4 of the time it's wrong. So all this is to say that dementia screening is a hot potato and it is not routinely recommended. So just because we know something about dementia doesn't mean we should be testing everybody for it. I promised at the beginning I would return to this, and I want to have time for questions, but I just want to address real quickly why dementia is a problem. It's not a problem for medical reasons. And how can we help people with dementia? We can help them by supporting them and their families. This is the single best book that I know of for dealing with dementia. It's about caregiving. The phrase says it all, working a 36-hour day. It really means that when you're dealing with patients with dementia, think about their caregiver and talk to their caregiver about what their experience is like, what the whole family situation, community situation are like, and don't just focus on the patient's brain. If you just focus on their brain, you're going to do a disservice to the patient and their family, and ultimately you're not going to come up with things that help them. And on agitation, just as you're going to get more of this later, but my brief take home is don't think of medications first. You'll be in settings where people have agitation and somebody wants to give a pill, and if you can be the force that says, hey, let's try something else, that will benefit patients a lot more than putting them on a medication that likely won't do very much. And as a reminder, if you didn't know this, antipsychotic medications have a black box warning in dementia. It's the biggest warning there can be on packaging, and it's there because there's about a double risk of death for people who take antipsychotics in the setting of dementia. All right, on that happy note, here's my email. I'd love to get questions from you, and that's all I've got for the material, and I think we've got time for some questions. Okay, so
we have a couple of questions.
I'll go back up a little bit. Are there people with none of the known risk factors who develop vascular disease? Great question. So pretty much no. Vascular disease is better worked out as a clinical entity. And if your blood pressure is okay and your cholesterol are okay, you typically do not end up with the consequences of vascular pathology, which would be like kidney disease, stroke, retinal disease. Also, I should mention blood sugars. So that is one of the advances of the last 40 or so years, is that with a better understanding of vascular disease and medications that target blood pressure and cholesterol and blood sugars, the rates of vascular disease have declined. So that had encouraged a lot of people to look into blood pressure medications or cholesterol medications as a way to diminish risk of Alzheimer's. My former boss here got a huge study where they were using these drugs to try to prevent Alzheimer's, and the very early studies looked fantastic. And unfortunately, when they did the big study, they didn't find any difference. So yet again, a case of how we simply don't have clear ways of preventing Alzheimer's. Thanks for that question. That was a great question. Here's a question. If someone has cognitive changes following stroke and does not recover cognitively, is this then called vascular dementia? And if not, how is the cognitive impairment classified? Great question. And that's one that we practically deal with a lot in our clinic. And it is not vascular dementia, because dementia is a progressive neurodegenerative condition. What that person has is cognitive impairment secondary to stroke, or cognitive to cerebrovascular accident, CVA. So it's important to categorize those separately, because for everybody who looks at the chart and the diagnosis, if they see dementia, they're less likely to engage in a rehabilitative model. You know, if you know this person's got what's generally considered a sort of terminal disease, your goal is not going to be to help them increase their activities and to recover. Whereas if you identify someone has a cognitive problem after a stroke, then there's still plenty of workarounds. So that it is, and there's a lot at stake. There's some fascinating older studies where they would take people like decades after a stroke and tie down their good side, if they had one side that worked well and the other that had impairments, and have them use the side with impairments. And people were able, even that much later, to develop new skills and abilities in the side that was affected. So even after a rather large stroke, you still sustain the ability to adapt, and your brain can create new connections and move forward. So that's it's not like the changes are completely fixed after a stroke either. Whereas in dementia, unfortunately, the neurons keep dying, and people can learn new skills, and certainly their emotional memory is still there and can adapt, but not nearly in the same way as if they had an intact brain structure. Great question.
So Stephen, an earlier question came up about delirium. You had said that it's an acute brain failure. Does that mean that delirium is never chronic? Great question.
So yeah, we call it acute brain failure to clarify that it's an organ system problem, to go along with like kidney failure or liver failure, where it's the whole thing that's not working. And when you see it that way, you also realize that if you have acute brain failure, your brain's not going to start working immediately afterwards. Like if your liver gives out, it doesn't necessarily, the next day you're not going to have normal liver enzymes. So if you follow delirium for after it has occurred and you know the cause, the symptoms persist for several months, which is a surprise to a lot of folks, especially on medical units where they have somebody who's admitted with a urinary tract infection, they're clearly delirious, they treat the UTI, the labs look good, and they call up the psychiatrist and say, why is this person still confused? And we have to explain, well, it's because it's an acute brain failure, it's an organ system failure, and it takes a couple months for their brain to get back online. So that's one part of the process, is that even when the cause is fixed, it still takes a while for symptoms to revert. The other part is that you can develop a subacute delirium that persists for months and months. And we see this quite often, that, for instance, people who have medication side effects, they're not full-on raging delirious, but they clearly are not working at 100%. And a lot of those other issues that I talked about before, like sleep apnea and unmanaged medical conditions, which would involve like really high blood sugars, could be considered a form of subacute delirium. Great question about delirium. And yeah, that's a good one to look out for. I thought we might want to do a delirium lecture at some point in this series, but it doesn't really fit exactly into this series.
We do have one archived.
Oh, great. Okay, yeah, fascinating topic. And you're looking for an area to work in as a career, I'd encourage that, because it's the field is really wide open about what causes and how to prevent delirium. Well, I don't see any other questions. Barb, did you see any others?
I do not see any other questions, so I think we are at an end. And Dr. Thielke, thank you so much.
Thank you. I really appreciate you all being here, and please all stay well. And,
yes. We'll see you next week.
We will. Okay.
All right.